think I've ever met anyone who's like, yeah, I want to be a doula because of all the horrible stuff that happens, right?
Yeah.
Yeah.
Yeah. Well, it's interesting. I think depending on what area you're in, that could be a calling that doulas would come to. Like in the States, a lot of Black women are coming to the doula work because they want to protect women from abuse in the hospital. And it's very it's actually very much like, for some people, like a response to the trauma that they are hearing that people are experiencing. So it's interesting. I mean, in some, like most, like I certainly didn't come to doula work thinking that I wanted to be a doula to like mitigate like people's trauma. But I did also, because I had a doula and I didn't have a traumatic birth at all, but post my birth experience, my experience with the hospital, it really made me realize that, and even coming into the hospital and sort of like the difference between all the warm and loving and supportive and encouraging and respectful like experience that I was having like with the midwives when I was at the office and at their center, and then with my doula, everything was different at the hospital. And so I was like, I do want to be a doula because I want to be able to like help people, support them, especially in situations where they can't have this optimal birth at home and they have to go into the system. How can they do that in a beautiful way? And it's interesting because I realized like in different, especially in other first world countries, I think the hospital experience may be different for families. And I don't know, that's actually something we probably get into because it's a very not midwifery, doula friendly per se in medical environment, but some of them are. And it just depends on where you are. And but generally speaking, that most doulas going into the hospital are partially feeling like they're there to protect their clients from like the system, whatever that is. Yeah.
It's an interesting thing to think about.
Like, was that at all your experience? Why you wanted a doula?
Something in me said home birth wasn't the right choice for me, and whether that's a retrospective, who knows? It's the woulda, coulda, shoulda, right? Who knows? But I think for me it was that feeling of kind of after it all happened. So after the first birth, I had a really large internal tear that wasn't picked up, and I was in a lot of pain, and it was kind of like, oh, well, these things happen, and lots and lots and lots of hemorrhaging. And I was like, had that moment of thinking, yeah, I'm going to die. Like, this is it. Wow. And I remember just feeling like so outnumbered. Like the more people that came into that room, the more medical it got, the less humanizing it became. And I just think,
the less you were in there.
Yeah. And I think I've spoken to people about this before, like all these small things when people are like, oh, what do you do? What do you say? I'm like, for me, one of the hugest things is like even just somebody like looking at my face and saying like,
yes,
it's going to be okay.
I'm still here.
Yeah. Instead of all this stuff that just happens around you. And I think about like, okay, so I'm a white, educated, middle-class woman in a, fairly expensive hospital. It still happened. Like, so then to sort of translate that into what it is like for someone who is petrified, who doesn't need to be petrified because we're all human, right? Like,
right.
It was just so much.
And when you say that petrified, you mean petrified because of what?
Petrified.
Like you said, because you said like as a white woman, are they petrified in that sense because they're like a minority in that environment, or?
I think there's different layers, obviously, but like one of them is people not realizing that they have any rights, like at all. And even just the language around, I tell this story a bit too. I remember because with my second birth, I went to like 42 and 2, and the amount of people who said to me, are you allowed to do that? I remember even like my hairdresser saying, isn't that illegal? Isn't that illegal? And then having a conversation about like, okay, so what did you think was going to happen? But then leading that to, they're like, well, for some people, some people are shackled during birth. That is still a thing that happens. So the sort of extremes of like, no, nobody's going to come and break down my door and force me to go to hospital and force me to give birth.
Right.
But actually, that is
Right.
something that happens.
Yes, it is something that happens.
Yeah.
And and people are not, some people are not allowed in certain instances. I mean, I think, in, gosh, I mean, I don't know any cases of this specific example in the incarceration system, but I think in an environment where you actually don't have actual like full right over your body, and then you're under the medical care of a system, I don't know. I mean, that's actually interesting. When you said that people are shackled, did you mean like in prison, or in what environment would people be shackled?
Well, the only system I know of would be, when people are incarcerated.
Okay, yeah.
That's all I know of. I wouldn't.
I know you would hope that that's not happening in another context. Yeah. But even the pressure, the psychological pressure that people have to be told, okay, so I'm scheduling you for a C-section or for an induction tomorrow because you're 2 days past your due date. There's never, like, I hear women telling me that's how their providers presented to them their option of that. They said, well, we're scheduling you, you're 2 days overdue, this is dangerous, we're scheduling you for your induction, you need to come in tomorrow or at 8 o'clock, make sure you don't eat or whatever, right? And so then there's like this sense of like, well, I don't know, the doctor said I have to go, what should I do? And it's like, well, did you ask any more questions about that? Because they actually can't come, like you said, they can't come to your house and make you come. And it's interesting because recently I've heard of a couple women actually just not going, like to their doctor, and then just, they didn't have they were just like, I'm not going. And nothing happens. Then 3 days later, they call you and they say, hey, you didn't show up. The doctor scheduled you for an induction. You need to come in, right? And so obviously, I think as a doula, I really want to know that my clients are in active care, like that they are getting monitoring. If they're, if you're at if there's a sense that you should be being seen to establish your safety, then are you getting stress tests? Like, is the doctor saying that you should come in for blood pressure or whatever it is? Go and do that. But you do have a choice, and you should have conversations about your choice. And I think that is something that I know when I do trainings with doulas, like the sensitivity around, you want to encourage your clients to make sure that they are fully informed and that they have their rights, like that they know their rights and that they are I wouldn't say allowed their rights, but really like the system is so intimidating for so many people that they don't realize that they're allowed to do anything. There's a woman in the community who has I think it's the podcast is Birth Allowed, and it's like this whole concept of, do people, do people have the right to allow you to do anything when you're an autonomous person? And how did you become unautonomous suddenly because you were pregnant or you're in labor? Yes, very interesting. Very interesting.
Oh, this is like, I'm just got so many thought bubbles in my head for things we could talk about. What's on your heart? What do you want to, just go for it.
Gosh, when you were, it's so interesting thinking about the comparison between our systems in Australia and the States. I'm curious to talk about two things, and this is somewhat different than what you maybe were thinking of, but I'm actually thinking, I really want to know like what your minority populations experience in the healthcare system that you're aware of versus like what the white population is experiencing, and how does that play in, if you're aware, as far as the sense that people have around their like safety in the hospital setting. It's a really big topic here in the States, and it's something that really affects the Black community a lot. And so I'm in conversations around that a lot, but a lot of other minorities in the States, immigrant families, definitely our indigenous, Native American population, has their own experiences on reservations, but also in, hospitals that are in the outer of America, and all types of sort of like, gender minorities. And there's so many different aspects where people are really feeling like it's not safe for them in the healthcare system. So I'm curious, what do you experience there in Australia around like cultural safety and lifestyle safety, I guess?
It is really mixed. So our system is odd in the sense that if you want continuity of care, what a lot of people do is have an obstetrician. So we have a lot of really overqualified people attending births that don't require, potentially, someone who has surgical skills. And so what happens a lot is that when you are trained under like risk management and you go into a birth, you see a risk, whether there is a risk or not. So we have a system where we have a lot of really overqualified people doing a job that isn't really what they're trained to do. And some of them are great at it, but I would say some are like, it's just like putting the wrong person in the wrong place. And so there's a lot of normalizing around things that go wrong in birth with increased interventions. So there's that side of it. But then there's also the midwifery-led care is still a thing too. Home birth is getting to be a much trickier option.
You said midwives. I was wondering if your midwives are in the hospital or in home birth or birth centers.
All over. But it is getting a lot more difficult for midwives with home birth because of insurance and because of we've got a lot of the situation where I'm in Victoria at the moment, where it's other midwives are like reporting midwives for attending home births and for like this, you know, that kind of sister wound stuff where it's not like the mum and the birthing person and her partner weren't asked, are you okay? Do you have a problem with this? It's just somebody stepping and going, well, how dare you do home birth? It's unsafe. It's this, it's this, it's this. So mixed opinions, but there are definitely, I always talk about it like warfare, right? So, you know, like you get the people who should be on the same side, fighting for the same thing, to fight with each other so that we don't see what's happening at the higher level. It's just, I think this is the biggest distraction that is happening in our country. Yeah.
Absolutely. It's classic sociocultural warfare.
Yeah.
Yeah.
So similarities, we don't have quite the maternal death rate that you guys have.
You do not, or you do have?
We don't.
Okay.
We don't. It's still not like as good as it could be, but I think it's I don't even pretend to like have all the answers on that one, but I would say
sure, but it's, you know, it's not an international disparity.
Yeah. So I think part of the work I want to do is make sure that we don't get stuck in this, oh, well, that doesn't really happen here, so we don't need to worry about it. That's kind of one of my big things. So I think it's really easy sometimes for people to do especially, you know, when you're in your bubble of what you do for work, to be like, oh, yeah, that's something that happens over there, to those people over there. And we don't give them names and we don't give them faces and we don't treat it like, well, actually, this is a human rights issue. Doesn't matter where you live, which is part of the joy and excitement of doing something like this. We're in completely different parts of the world, different experiences, but, you know, you come together for the one goal, right?
And I love that because I feel like we have to learn from each other cross-culturally. We have to learn from each other internationally. It certainly shouldn't be the case that people will think, oh, well, that's not happening here. It's not going to happen, because it's a progression of things that are happening and not happening. And I do think it's interesting, you know, the interplay with insurance, not covering midwifery care, and if that's happening more than it used to, or if the model somehow is shifting where there used to be more births with midwives and now they're more with, you know, OBs, it's going to shift the climate, you know, pretty quick, you know, as less people have access to care that's intentionally non-surgical. And so there's just a lot more. I always say, like, if you have amazing skills and you're in the room and there's a problem, you're going to want to use your amazing skills on the problem. So it's a natural default that surgeons will want to use surgery more often than not when they see a problem. Just like it's a natural default that midwives who will not do surgery will find every way to bring a life to safety to the world without surgery, right? So you have, you know, two competing sort of like concepts, systems there. But I think, you know, going back to I think it's very interesting to be in a position of having had birth traumas and then noticing that the person that was there to serve you, I mean, for one, both the medical system, which was like sort of ignoring your presence as they're like getting ready for the emergency response, which is somewhat understandable, but I do a lot of training medical staff too around how to respond in emergencies and still like maintain the humanity of the person on the table. Like, it's so just a moment where somebody turns to you and they say, look, I know we're moving fast. I know there's a lot of people where, you know, where we're thinking of you, you know, just try to relax as much as possible. We'll try to tell you as much as we can. We're not going to be able to tell you everything. I mean, I had a group of doctors, you know, and nurses and like medical folks when we were having these conversations, and they were saying that, well, you know, there's so much going on. Nobody has time for all these niceties, you know, like it was almost like they were irritated, like with the convenience of you telling us that we should, you know, be kind and careful and considerate when we're in an emergency. And I'm like, I've been in emergencies. I've been in life or death emergencies. I understand, as a psychologist, working with, you know, highly mentally ill people, working with highly suicidal people. I've had people with razors in their hands, with knives over their throats, with nooses on their necks. I mean, I understand that you have to respond a certain kind of way. But at the same time, there is something that is important in that kind of human response that can help control the scenario. You also have someone's blood pressure, someone's heart rate, someone's sense of well-being, or someone's anxiety that can impact their physiological body. And so, you know, and just to remember that once they're off your table, they're going to go home with everything that happened, and you're just like going to go on to the next person. And so I was telling them, I said, then if it's so much for one person or to do who's in the middle of it, then designate the minor, you know, nurse assistant or the residents, or designate people on the team to, when there's an emergency, that they are the ones to do communication. I mean, in your case, you had a doula who at least probably was trying to find a way to center you. You know, I hope that they weren't like just in a corner somewhere in shock, shaking their head and, you know, like really overwhelmed, right? Like that, you know, a doula is going to do their best to try to stay present. But imagine, you know, as you can imagine, people who don't have anyone there, and it just becomes this big takeover. When we talk about trauma, you know, as you know, in mental health, it's so much more about the perception of the person experiencing it than what happened, right? So you could have had any situation happen and have 17 people tell you that they're experiencing trauma symptomology differently based on what happened. Maybe there were two people in the room or two people next to each other when there was a trauma. And so it sort of mitigates it when you have someone that you're traumatized together with, or they might have debriefed it in a way where they could really talk about their feelings after. And so, you know, I try to think about like the classic psychological first aid, and like when I'm training doulas around, you know, thinking and the health providers around what would you need to think about related to birth trauma in the middle of it, but also after. Some of it is processing out the experience. And if you can process a traumatic experience in the middle of the trauma, like, you know, I always tell people, think about like with your children, and if something dramatic happens, right? You could be in a situation where there's a car accident your child witnesses, or somebody is having, you know, a panic attack in the street and your children are witnessing it, or there's an emergency with another child. How do you manage your child? You know, you quiet down, you look at them in their eye, you sort of get their attention, you know, and so just like we do have a way that we care for each other as humans in different scenarios, that somehow in the hospital room, it like kind of goes out the window. It's like somehow you don't need the care that you might need if the same thing was happening tomorrow or the day before and you were in a regular outfit on the street. You know, like if something happened and you're suddenly bleeding unexpectedly and a whole bunch of people are coming in, even if it was doctors and ambulances, I mean, your modesty, people would be thinking, oh my gosh, we're in the street, cover her. Like, you know, people would be asking, you know, how you're feeling. Oh, I know this is so much, just take care. We're going to help you out. I mean, that's the response of first responders in the world. And we just have to bring that more to the birth room, because a lot of, you know, women and families and doulas are coming away from these situations feeling very traumatized. And when I listen to them talk about it, the trauma is not so much about what physically happened, because we can endure pain. Let's say, you know, there was a need for them to do, when I had my first daughter, I hemorrhaged a lot at the end. And they were like going in with the towels and the fists and the hands. And I mean, I was overwhelmed with the level of sensation of what was happening as I had just given birth. And then they're like trying to stop the bleeding. And it was super painful. I remember that it was painful. I don't feel traumatized about that at all. Not a little bit. I didn't, I mean, it was, I don't even think I thought about it again, except for explaining to people, you know, sort of like over, you know, like in my medical history that I hemorrhage, and then they're like, well, how much did you hemorrhage? And then I'm sort of describing, like, I'm describing all the towels soaked in blood, and they're like, oh, yeah, like you had a real hemorrhage.
It's such a quantifiable thing, isn't it? I found that too, that people always want to know, well, was it this or was it that? It's like when we talk about, you know, sexual assault and things like that. It's like, that's not actually the important part. The quantifiable information is not the most important part.
It depends on who you are, right? Like if you're, and it's a great point. Like, I guess if you're the medical provider, you want to quantify it to get a sense of the risk of hemorrhage for the future, or what the medical scenario was, which is still insensitive to the person's experience. Like nobody's ever asked me, what was it like to hemorrhage? Nobody's ever asked me that. You know, like, what
nobody's ever asked me either, actually.
Emotionally. You know, but when I recount, I mean, it was pretty intense. You know, like I was, you know, my ears were ringing and I couldn't really see. And I was in a haze, and I thought it was all like afterbirth joy and excitement. I totally received the perception of it as blissful, and because I had just had the baby. But I was also aware that there was a lot going on. And so I say that to say, you know, my experience of being able to sort of accept that I had this pretty painful afterbirth situation, but I don't experience it as trauma because my doula explained to me what was happening. I did become very resistant to them wanting to use Pitocin, and I was like, no medication. It was like in this fit of like remembering that I wanted an unmedicated birth, and I wasn't really thinking about the fact that the birth is over. You know, and she was able to sort of center me and, you know, let me know that this is very medically necessary. Like you need Pitocin. We're, you know, having a hard time stopping the blood. And that was really, but because I had her, it didn't feel like anything. It was all like this loving, warm experience after. But people could have experienced same sort of perception of pain, right? They could have a massive amount of pain, but because people were talking at them, it was a fear-based situation. If the midwife or the nurses or an OB had come in and said, ma'am, you need to lay down and we need to do medication because you're bleeding and you could die. And if they, you know, sort of like got hostile with me, it would have been a memory of trauma. And I would have felt violated, and I would have felt pressured, and it would have taken away the joy that I was experiencing, you know, and I think that we have to, as much as possible, sometimes birth can have unexpected twists. You know, I've been in, you know, a number of births and consulted with families and birth workers where it did not go as planned, and it was really traumatic and it was scary at moments, but there's still a way to center the mother's experience so that she doesn't pick up on any of that as much as possible, unless it's necessary. I mean, sometimes you have to bring people's attention to, like, we need you to focus. Like you know, like, you know, there's sometimes like where people kind of dissociate themselves from the experience, but they're needing to be present more to push because there's like the baby needs to come now. This is like the baby's been down too long. You know, we need, like, we got minutes before we have a problem, or, you know, then there's sometimes a need to say, to bring the birthing person into focus. But you know, there's such it's a skill, it's an art, it's a heart space. You know, I definitely think it's the work of the doulas, but they do, unfortunately, because of the scenarios that come up, both interpersonal and sort of medically, there is a need for more awareness around how to manage birth trauma and the vicarious trauma, as you said, for themselves.
But it's a teachable skill.
Definitely.
Yeah.
Definitely. And it's not like something you have to learn in school per se, because it's experiential. I mean, all of these physicians and nurses have gone through school and they don't have this, you know, and we all are taught communication skills, you know, that's basic, you know, reflective listening. I mean, those are courses that somebody took at some point. It's the practice of it. And, you know, I think if I think of like some of the other key things that can kind of help mitigate birth trauma, I think explaining what's happening when other people aren't explaining it is helpful. Like I've found in birth situations and outside of that with people just having like emotional trauma responses, that like if there's a lot of activity happening, just literally like translating the experience in a calm way is like a new narrative for the mind. Like, all this is happening. Oh my gosh, what's happening? And the this, and well, the doctor just said, because sometimes you're, as a doula, you're in the room, they're telling the family, this is what's happening. This is why we need to do a C-section, or this is why we need to do, this intervention, or, and it's all so overwhelming that they don't register it. And there's no, it's like there's a rush. Well, do you understand what we said? Well, you need to sign this paperwork. And so just being able to give the family a chance to sort of reflect on what was said and repeat it, like literally just, sometimes I'll do that with everybody in the room. It's like, okay, I'm looking at mom. She's not looking like she's really understanding. And it's like, okay, so what I heard you say, and I'm looking at mom, so I'm not like trying to talk to the doctor. I'm trying to like talk vicariously through mom, like, well, what I heard him say is that, he feels like blah, 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 and it's time to do this. How are you feeling about that? Like, do you have any questions about that? Like, I'm really like wanting to like facilitate that discussion. And then it's like, well, I just don't understand why that will be necessary. It's like, and I just sort of pause, look at the doctor, like, that was a direct question, and then like, that can be helpful because it's very, like, when you're feeling traumatized, especially if you have a sexual trauma history, if you have personal trauma history, or just like, if this is the first time you've ever experienced something where you've lost control of what you expected to happen, and it's like something's painful or, you're not anticipating, just to be able to have the reminder that you get to ask questions, that you get to speak, that you get to be unsure, that you get to say, I'm not comfortable with this. Do I have other choices? Is this the only other option? Because sometimes, in that fast-paced medical world, there's just like this agenda to just hurry up and go. And if it's an emergency because of time, that's understandable. But there's a lot of times where it just feels like it's like more convenient to hurry up this conversation because there's more people to serve. And it's easy to do that in a system where you have 10 births at a time happening all throughout, and there's one doctor circulating. I mean, there has to, it's unfortunate because the system as it's set up is unfair to providers, like to medical providers, because most of them are wanting to give time. If they could spend more time, they would, but they also know that they have somebody else in the next room, and they're trying to manage their awareness of all of that and be present with you at the same time. It's a lot to ask a human to do. So I'm always like wanting the system all together to like create a structure that's different, hire more present, providers on deck to be more one-on-one, have an expectation that they spend more time in the room if needed, so that there isn't this pull for managing so many people at one time, which is going to come off as insensitive sometimes and is going to end up being harmful, especially if people are in a vulnerable situation at times.
Would you be happy enough to talk to me about times where there has been coercion and there has been fear and there has been, I suppose this is the thing I wonder about, like the amount of times that we can talk about the awareness of bias, but then do people actually act on it, or do they like, oh, well, I have awareness. Like, awareness is great.
Yeah.
It's the action part that seems to be a problem.
Yes. Well, I think awareness with specific stories that are related to what you do every day that you have to come up with, it helps. So like when I teach like implicit bias and cultural humility, I'll do the beginning where I set up the whole concept, right? And then I give all kinds of examples, like, the examples of, race-related, implicit bias, and gender and sexuality-related implicit bias, and then sort of socioeconomic implicit bias, and how your own personal worldview is going to narrow the way you see things. But then it's like, now let's talk about what you see every day. And a lot of times it'll be hard for people to want to give those examples. And so I'll start off with, okay, I'll give you a few examples from the community at large. There's been a number of focus groups with, communities that have expressed having obstetrical violence happen to them, race-related microstressors, just prejudices, discomforts, sort of not trauma-informed ways of caring for women and families. And so I'll give examples. Like one of them is a lot of the women who gave reports during this focus group with Black Women Birthing Justice mentioned being pregnant at some point as teenagers. And one of the stories that the woman told was that at the point of pushing, one of the nurses had told her, you know, you can't push yet, the doctor's not here, like that classic thing, right? Like whatever. Like,
yeah.
I always say the sensation that has brought life into this world since the beginning of time. You want it to wait for a person to come into the room, to just stand there and wait until it comes out, and then
because no babies get born unless that
right,
happens.
Right. Like where this is all still going to happen here, and then you're going to just, anybody could have reached out and make sure the baby doesn't land on the table. So, and I mean, not to oversimplify, there are times where there's assistance needed and positioning and all that, but really this wasn't that situation. So every time she was pushing, she said the nurse smacked her legs. I said, stop pushing. The doctor's not here. Why are you pushing? Right? Like very disrespectful, very mean, very aggressive. And she felt very, you know, she felt very emotionally wounded by that, obviously, and was enough to have remembered it many years later. She was now an adult and sort of recounting the births that she's had with the system. And I've given that example, you know, a lot when especially with like labor and delivery nurses and in medical OB setting. And people are like, oh my gosh, that's so terrible. And then I'm like, okay, so that's like terrible. But the pressure that the nurse felt about her not having the baby, is that unreasonable? No. I mean, of course, and then they go on explaining. So then the doctor gets in trouble if he's not there for the birth, and the nurse has to chart it. And so then he'll get her in trouble, or she'll get her in trouble, or whatever, whoever is in the one, you know, for not having the doctors be there. And there's like this demerit system, and every hospital's got their own way of doing this. But there is a pressure that's put on the client that's all based on the needs of these people at higher levels. And not necessarily at all considering the fact that it's an unreasonable request to start out with, as far as I'm concerned. And so then it's like, well, how have you heard people tell moms don't push? Which most of us on the receiving side of having pushed, especially having pushed without, you know, epidurals, where you have the sensation of your body. That just telling me that I shouldn't push sounds like violent to me. Like it sounds like oppressive to me. It sounds aggressive. Like, what do you mean? Like, don't push. I don't know. Like if somebody was vomiting profusely because they were ill, and you say stop vomiting. Stop. Like there's no, you know, what am I supposed to do about this, right? Like, and so you telling me to stop doing something that's happening to my body is like forcing me to try to restrict something that really puts me in a bind. And so then we get into conversations, well, how else have you heard it? You know, and then it's like, when you're feeling at your most anxious, 2:00 in the morning, you've already accidentally had a mom push and the doctor missed it, and you know you could get in trouble. Now how do you talk to her? You know, and it's like sort of teasing out the reality that there's a lot of times where people are feeling pressure for whatever reason, and they're acting out on their own internal feelings, and that having nothing to do necessarily with the client. And then I'll say, now, if this client is a person that looks like you, how differently do you think people might respond than someone who looks like a group of people in the community that they don't have experience with, that they're not terribly comfortable with, or that have a lot of negative stereotypes? How do you think it would be different if the woman, you know, let's say is African American, if you're a white woman, or if this is a immigrant person that doesn't speak English, or if this is a transgender person that doesn't present as female and has a partner that you don't identify as someone that, like, how does it change that when now there's some other additional thing added into the space? And there's just so many things to sort of like unravel when we're looking at what it looks like for people to be mean to each other, you know, in a setting. And to not think that just because you're a nurse or you're a doctor, that you somehow lose the pettiness of humanity when it comes to, you don't really care. So, I mean, this isn't a person that makes you feel like you need to put on airs. Let's say this is a person who doesn't have good hygiene, or someone whose hair looks messy to you, or someone, you know, like there's so many different levels of somebody that's by themselves. I would often tell people the stories that I've heard people tell when they were by themselves in childbirth. You think you know the colleague sitting next to you, but you don't know what they do when they're by themselves with people. And a lot of times, you know, especially, you know, at-risk populations, minority groups, just various, you know, if depending on the area you live, people go into birth spaces by themselves. They don't have the support. Somebody has to work. You know, they may be a single person, whatever it is, and nobody even knows how they're treated. And a lot of times they don't necessarily feel like they have the right to report people. They don't feel safe to report, because how do you report into a system that somebody of authority does something that makes you feel uncomfortable? And these are the things that are uncomfortable to talk about, but we have enough case studies, we have enough focus groups, we have enough reports from communities all over, especially in the States, from multiple states, multiple socioeconomic levels, saying that they were treated in a way that was disrespectful, and then having other people not from those communities saying, oh my gosh, that's unbelievable. You know, so it is, I think the stories can help people think about when it happens again, like how they'll do it differently. And I just always encourage people to buy and read these case studies and focus groups and reports. Like when communities, especially locally, come out with community-based, those are always the best, because they're unfiltered. They don't take out the things that would make, you know, an insurance company or a certain hospital feel bad. They usually will take the names out, but you still get the point of the stories of what's happening. And I think it's significant because people need to know it's like a real thing that's happened. I mean, obviously there's so many cases in the States where, you know, Black families had medical issues that were not attended to, and then the woman dies. And there's all this question, oh my gosh, how could it happen? But when you listen to stories of particularly Black women around the nation talk about the way they're treated, it's not surprising that if you would treat someone who isn't dying in a disrespectful way, if they happen to be dying and you don't know, you're not going to listen as much anyway. So, you know, we've got some work ahead of us about like really just coming back to the humanity of why we're in our professions, and remembering that it makes such a difference the way we are with people each moment, because for you, this is one person out of 25 in a day. But for this person and this family, this is their first child and the birth of their first child, or the birth of their second child. It doesn't matter if you have 10 children, those are still only 10 experiences of your life versus thousands that you won't remember. And it does make such a difference for bonding, for the breastfeeding after, for the memory, and sort of like, if you think of, you know, on the psychological level, the first memories that you have of bringing a certain child into the world that were very troublesome or very abusive, you know, you had an abusive situation or you had some trauma. I've heard families that I work with young children or even with teenagers still talk about, you almost killed me. I brought you into this world and it almost killed me. You've been a terror since you were born, right? We've heard people say this, these narratives. They don't leave you. And if you have people that can honor you if you did feel violated and give you time to heal from it, so that doesn't have to be a wound that sort of, you know, oozes for the rest of your life. Or if you have people in the midst of a trauma, mitigate the trauma by communicating with you and sharing in the difficulty of it, and giving you options and helping you feel like you have some level of autonomy, even if it's, well, we're going to have to do the surgery, but, you know, do you want us to play music? A woman was saying that the OB was asking her when she had to do a C-section, all of her wishes for the C-section. And she was just thinking it was going to be so terrible. And in the end, she felt so loved and cared for by the team, because they knew she didn't want that. And they thought of what they could do to make it easier for her. And so they played music, and I think they, I don't know, they asked her about like the outfit of the baby. Do you want it to be this color or that? Just little details to make people feel like you just want to be seen. You know, that's really all.
Talk to me about this idea. I'm curious. I have a sense of what you're going to say, but I'd be interested to see how you say it. When people say, oh, doulas are not meant to be activists, doulas are not meant to be advocates, what do you think?
You know, I think that comes from a privileged place. I think anyone that says that has experienced a life where they have not needed advocacy very actively because they were in a position where they had some level of autonomy and power, or they felt like they could get the resources to do that if they didn't in the moment. And they've never really experienced people who their whole life is like, you know, a big suppression, and, you know, with a lot of, you know, challenges and stressors that are coming from the system, not the individual. And so I, you know, I was, you know, at a conference recently, and this conversation has come up in the doula world a lot about doulas as advocates versus, you know, not. And one of the things that I was sort of talking to a couple of colleagues of mine, other women of color, and then having this conversation with a majority white women doulas, is that I find that this conversation about advocacy or not is more of a conversation that isn't in the like women of color community. Like this is like a given that we're going to advocate.
It's a no-brainer. Yeah.
And what it looks like is going to be different based on the style of your personality, your client, the needs, the setting, the safety of you and your client to actually be able to facilitate this advocacy in that setting versus after or before. There's a lot of nuances that we are pretty comfortable talking about without it needing to look like you do it just like me and I do it just like you. But I find that among a lot of the white doulas in that birth world, that there's this rigidity about agreeing on what it looks like, on a consensus, you know, this idea of certification and licensure. And, you know, it's very much, you know, a part of the dominant cultural model to have standardization, to have a universal way that everybody does things. And while there are benefits to a universal sort of structure or accommodations and sort of standardized understandings, the individualized care is so precious because people are human and they need different things. And as a clinician, and this is not that a doula is a clinician, but as a psychologist, one of the key skills that we have is over time, with enough experience, with enough patients and enough clients and enough settings, you understand how to deliver the services to the tailored needs of your client. That's the skill that we develop over time. And to me, that's the skill that all providers develop over time. But this idea that like you would sort of keep doing it in a rigid way and not shift if there was a need socioeconomically, if you move as a doula to a community where there's, because what is our role? I mean, for instance, you know, this idea of, you know, an uninterrupted, you know, presence in your birth of a person that's with you. But what if somebody says that you can't be with them? What if the provider says that you have to leave? Do you just walk out? Do you ask your client, knowing that it's their right to have a person with them in almost every setting? It's like a part of your rights to have the support of your family. Is it because if you know that this person has trauma or that they're really anxious, so that you've been working with them for months now, and they don't know any of these people, even if they're providers in whatever way, and that they're, you know, there's a bond and a trust, and you're, you know, they're leaning on you to turn to your client and say, how do you feel about me leaving? Is that okay for you? Now that's the way, if you notice, like I'm always sort of like giving these examples where my relationship was with my client, and I really address them so that they can clarify for me out loud to the world what they're wanting. So my version of advocacy typically doesn't look like me addressing a doctor or a nurse about what they're doing. I have heard of situations that I can imagine if I was there, you know, where, you know, there was a situation where the OB the woman had said she didn't want an episiotomy. He pulled the scissors out and he was already ready to cut. And mind you, she's like sitting back, so she can't really see what's happening. And he's going to cut. And I want to say that the doula, like, you know, kind of like blocked the hand or something like that, or that was sort of like something about the story that I heard. And people were like, well, you can't do that. You can't, you know, interrupt a medical procedure. And it's like, yeah, but you can't go against your client's actual professed like statement of what they don't want. I mean, you can, but that's abuse. Like that's actually obstetrical violence, to forcibly cut someone who can't see you doing it, right? So in this situation, you know, what would a doula do? Whatever they felt was most appropriate. And I would never like micromanage, even like as a trainer, how they should mitigate that. Nor would I necessarily encourage, I mean, you know, like that you hit the doctor. I mean, now you're going to have an assault situation yourself, right? I mean, but to say that in that moment that you shouldn't advocate, are we advocates or not? What does that mean? So if you're there and the doctor is about to cut her and she has a birth plan that you've communicated to the team, and you know that she has no idea, she just got off of a contraction and she's sort of just taking her deep breaths, and this is like his moment because she's distracted. What are you going to do? Now, if you sit there and you don't say anything and you allow the episiotomy to happen while you're sitting next to her and you're witnessing it, I don't know. I mean, I almost want to say, let's put this on the clients. What do you think about a doula that you have been working with and you paid them to help you have a birth a certain type of way and to protect your sanctity of your birth plan in the sense of understanding it, remembering it? There's like every 8 hours, there's a new nurse, or every 12 hours, right? We could be there for 3 days and we've had so many different people that don't even remember the birth plan. Part of my role is to make sure that people remember what you wanted. I think it's my role to say, oh, wait, doctor, you know, she said that she didn't want an epidural. Can you wait a second? When she finishes her contraction, she'll probably tell you something about that. I don't think there's anything wrong with that. And I think that you are calm and you have a respectful presence. You're not antagonistic. You've been, you know, actively engaging with the birth team. I think in a very team approach, I think we're all needed. Usually at the end of a birth, we're all shaking hands and hugging. Like, you know, I feel like, you know, I've never had a situation after, maybe in the beginning, there's some initial guardedness to my role as a doula because people have their own whatever, but they see that I'm just here to assist the mom in her experience and staying calm and breathing. It's usually a benefit to them because they don't have to stay with an anxious person. And, you know, we're all there to support mom, aren't we? Right. So I just try to like remind everybody, like, you know, to center. So I think, you know, those are my thoughts on that. I think that, you know, I don't know a situation when people ask that, not you, but, you know, when it comes up in the community, I'm wanting to hear, tell me the scenario of advocacy that you feel like you should stay silent. What does that look like? And why are you silent? Like, and who are you silent for? And what is that silence doing, right? Like, what is the ultimate goal? So that the doctor smiles at you and is happy that you were a quiet, complacent person and didn't interrupt their system, even though, you know, like you're a good girl doula. You can come back on this floor anytime, right?
Gold sticker for you. Yeah.
You know, I mean, my only thought in birth not only, but the central thing is, how is she experiencing this right now? How is she feeling right now? That's like always what I'm trying to be a keeper of. So if she's calm, I'm wanting to keep that. If the doctor comes in, I don't care what, and I mean, if we all know there's no emergency and they're loud or they're on the little walkie-talkie as they're coming in from the end, and I will go over to hey, she's in a contraction, you know, not like in an aggressive way, but like, you know, we're all on the same team and mom's like doing her thing. So remember, be quiet, you know, I may have the lights off and then they come in and they turn the lights on. Hey, mom, blah, blah, blah. I just give them a little, like, to me, that's advocacy.
Yeah.
You know, it's not like, I don't know what people think advocacy is. The other thing I think is that a lot of times when people use terms, they have a definition in their mind.
Yeah.
It's totally different than another person's definition. So,
I think so too.
It's very hard without the operational definition of what we're saying. Maybe there are people out there that are talking about physically, you know, not physically fighting, but, you know, yelling or being I've never heard anybody give me an example of that as advocacy. Like what I know people doing as advocates, they are making sure that the team understands the birth plan. And when people do things outside of it, they're protecting it by speaking to it in the room. There's nothing wrong with that. You know, they are asking, you know, clients, or sometimes even addressing doctors and nurses. I don't like to do that because and this is more, I think, like psychological savvy around like, how do you help people help you? And I find that when people are in a position where they want to maintain dominance, and not that all providers are like that, but in that sort of like, this is my hospital, this is my birth room, this is my patient, getting in a fight with you about who has control over her is nothing. Because as far as I'm concerned, she has control, right? Like, you can think whatever you want, and I'm not trying to be in control. But if I can recenter her voice and her wants, or the family's voice, or the partners, then that just like brings it back into the space, and it's not about me. It kind of circumvents this, like, if you want to make a war with me, the doula, I don't give you that opportunity, because this isn't about me. That's my point. This is about her, right? So I always, and usually a couple of times of sort of facilitating the switching of the conversation. Maybe this is like from mediation training and like, you know, couples training, you know, like all the sort of skills that you get working with like interesting scenarios. You know, I find that people, they get it. They right away, oh, okay, yeah, mom, so any more questions? Sometimes they're even obnoxious about it. I know you're going to ask if there's any more questions, if there's any other options. So these are the 3 options, right? Like, and it's like, whatever, we just want the information, you know? And some people are awesome too. I mean, you know, we get hard on the for medical providers, but I mean, they're coming far and wide trying to figure out what they're doing wrong these days, and like, why is everybody so upset? Like, and I think once we tell these stories, they're like, oh yeah, that's, you know, we kind of do that a lot, or I've seen my colleagues do that, and I'm saying the same thing to them. You should advocate like for that, like for that client. Like, you should like, if you know that this doctor is always doing episiotomies when people didn't ask, like, you should do something about that. It is your role as a health provider to advocate for the needs of clients. You know, so, you know, this is a conversation I think it's for everybody.
I'm wondering then, like, with our psychologist hats on, this is something I wonder about a lot. Is it potentially, when we're using all those A words, like, is it that people don't get the difference between assertiveness and aggressiveness? So they think, I think so. Activism actually just means being aggressive. You're like, no, it just means being assertive in whatever.
Right, exactly. It just means actually having a clear, like, goal of autonomy and rights, and then affirming them in a space. That's all it means. It doesn't, it doesn't, right. It's not necessarily with a picket. It's not with, you know, a loud voice. It's not aggressive. And it's funny because we really tease that out a lot, I think, in our field around just as we typically are, if we're in community work or even in interdisciplinary teams, we are advocates for our clients in many ways. And that never or rarely looks like us, like, standing up in a meeting yelling at people about, you need to do this for my, you know, that's just not what that means in that context. So maybe it is like an opportunity for us to redefine it for the birth world or with the birth world around, what are we saying when we mean advocacy? And I just want, you know, I know that the fear, because I always like think about what's the fear that everybody has about the idea of advocacy.
Yeah.
And that I think that doulas will be kicked out of hospitals if they advocate too much for their clients. And that advocacy means that doulas are taking a medical role. That's not their place. I've heard that a lot. And that we would lose our sense of where we are in the space, right? And so I think if you redefine that advocacy is just clarifying the rights, which hopefully we're all on the same page that we have rights, and that those rights should be honored, and that when they're not, that there needs to be some mitigation of that. And in the moment, if they can be mitigated, I mean, what we try to do as doulas mostly is teach our clients and families what their rights are, what the various stages of things are, so that they know if we get into a situation, these are the things to ask, these are the things to understand. But sometimes there are unexpected things, but also sometimes clients don't remember anything we've said because they're in the middle of labor. And so to uphold those things, I think we would agree that they're important, But I think there's a lot of fear because of like social conditioning, and really because if we were a fleet of male doulas in the world and we had a skill, and we knew our profession very well. We knew how to calm people. We knew how to, we knew the course of the medical sort of terrain and what the medications mean and this and that. We understand it for educational purposes. We're not prescribing, we're not recommending, but we're making sure that our clients in this fast moving system do know and understand what's being said to them. If there's a breach in that during labor, is that no longer something that we're finding important to do? And why can't we figure out a way to have that conversation with our clients, with providers, in a way that's not like antagonistic? Who's perpetuating this idea that that is antagonistic? I know that it exists in that medical hierarchy. Even a nurse, I've seen nurses say, oh, I wish this other doctor was on now because I know that doctor would do this, but this one is like this. I'm so sorry. And I'm thinking, well, if you know that there's an option, can't you suggest it? Oh, no. You know, we don't get involved in the doctor's decisions. But is it getting involved in the decision to say, is there another option, to ask a question, right? So I think, you know, and if it is, and the medical world has such a problem with families being informed and knowing their rights and asking more questions when they have questions, then we need to continue to push back, because it's not appropriate to push people through this assembly wheel of birth and leave many of them traumatized, confused, unsettled. I mean, just because nobody died doesn't mean that there was no harm. And I think that there's a lot of harm in fear-based coercion, you know, and the kind of pressure. And I think that when it's too much and you see that it's too much for your client, I don't think that there's anything wrong. I've had situations where my clients have broken out in tears and bawled crying as the doctor's explaining something to them. And they're just going on with their, well, you know, because this situation, so, well, the reason why, and then she's like, oh my God, and I'm like, can we pause for a second? It seems like mom can't hear you anymore because she's crying, right? Like, can we acknowledge that there's something happening here, and just like, and then, you know, what is making you cry at this moment? Like, what about what you heard is so difficult? Like, what are you confused? Are you afraid about something? Because maybe the physician can give you an answer that would make you not afraid, right? Like, they're still here as a resource. While you're in the room, we need you to mitigate this problem here that you're like sort of overlooking. I think that's awesome. And I'm telling you, I have seen more providers respond positively to the opportunity to be more human with their clients because they've forgotten than not. Very rarely. I mean, maybe once or twice I've had, you know, people seem to feel like it was an inconvenience that they had to keep answering questions. But to be honest, this is my client. And my client had questions, they got them answered. They made a decision that they felt more comfortable with, or at least they lined up with the decision that was being made, and we moved on.